Bismillahirrahmanirrahim. So, continuing our last lecture in which we discussed metabolism and excretion. Mainly, we were discussing metabolism at that time, and today we are going to finish off metabolism and excretion. So, phases of metabolism we were discussing. There are two phases, phase 1 and phase 2. I told you where these metabolic phases occur. So, phase 1 reactions include oxidation, reduction, and hydrolysis. We discussed in last lecture. So if we discuss the types of phase 1 reactions, so if you remember, metabolism is what these are the chemical modifications in the drug so that the drug can be excreted out. So for making a drug chemically change, so making a chemically changed drug, we need chemical reactions that occur within the body. So within the body, if chemical reactions occur, they need enzymes. So enzymes, we have already discussed what type of enzymes are used in metabolism. So for chemical modification, enzymes and other thing that is required is chemical reactions. So enzymes will act and will fasten those chemical reactions, so thereby ultimately changing the drug to more polar drug, and it will be excreted out easily. So the first reaction is oxidation. So oxidation is addition of oxygen or removal of hydrogen carried out by oxidases. So there could be mixed function oxidases, and there are many other systems like typically involved. So these reactions or oxidative reactions are typically carried out by cytochrome P450 enzymes, and how they'll be carried out we will see in a bit of time. So for example, the common reactions include alkyl group is this is, if you remember, this is C2H5 or CH2CH3 ethyl group. So that is also called as, the generically we can call it as alkyl group. It can be converted to alcohol. So addition of oxygen or removal, it is CH2, one hydrogen is being removed. So you can see the oxygen is being added up. This is all called oxidation, and the drug is now more polar. It can be dissolved in water. Then there could be aromatic ring. Aromatic ring is containing the benzene or the cyclic ring. For example, phenol. Here is the example. This is the benzene. Benzene is being converted into phenol. So example is phenytoin. Phenytoin is a drug for used for epilepsy. This is metabolized by this type of, or this has an aromatic ring, and oxidation reaction occurs to metabolize this drug in phase 1. So S or N position, for example, this is the sulfur containing drug. Here the addition of oxygen at the sulfur will cause its metabolism or metabolic phase 1 reaction of this drug. So for example, chlorpromazine. Example of the drug is chlorpromazine. Then the second type of reaction is reduction. Reduction is adding up of hydrogen or removal of oxygen into any group. For example, any drug is called reduction. So here azo is nitrogen or nitro groups NO2, it becomes amine NH2. This is called reduction. Then the third type of reactions that occur, metabolic phase 1 reactions, hydrolysis. Hydrolysis is addition of water with breakdown of one molecule. So here you can see this is where you can HOH is added, for example aspirin to salicylic acid. So the chemical name, if you remember the nomenclature of the drugs, The chemical name of aspirin is acetyl salicylic acid. So acetyl group is being removed by the addition of water, and salicylic acid remains there. Then we have phase 2 metabolic reactions. Phase 2 metabolic reactions are once the drug is set up for further metabolism by phase 1 reactions, then the phase 2 reactions occur. For example, conjugation reactions covalently add large polar endogenous molecules to parent drug or phase 1 metabolite, inactive and excretable. So what are these terms? First of all, the phase 2 reactions are conjugation reactions. Conjugation reactions means these are synthetic reactions. They synthesize something, they add up more polar substances, and where those substances come from. In phase 1 reactions, enzymes play a major role. In phase 2 reactions, enzymes play a major role as well, but there are certain other things. For example, endogenous molecules. Endogenous molecules means the substances that are present within the body. So adding up those substances that are already present in the body, for example in liver, these will join, or these will be conjugated with the drug molecule to increase the polarity. And how they'll be joined together, the drug and the endogenous molecule, they will be joined by covalent bonds. These are large and polar. So anything that is attached, anything that is polar and is attached to a drug molecule, it will make the drug molecule polar. So what kind of drugs it can attach to? Number one, parent drug. Parent drug means a drug that does not go in phase 1 reactions, or any drug that has undergone phase 1 reactions, that is called phase 1 metabolite, we just saw here. So this is the parent drug. If this drug doesn't undergo phase 1 reaction, this can directly go into phase 2 reaction. But if this drug has undergone the phase 1 reaction, and this is the phase 1 metabolite, and this can undergo the phase 2 as well. So what are those endogenous, large polar endogenous molecules? Glucuronide, glutathione, sulfate, acetate, amino acids. So these are endogenous substances. So if we see glucuronidation, so if you see the glucuronidation at glucuronic acid, in biochemistry you might have studied that the glucuronic acid is present in the body, and the main conjugation reactions in the body occurs through the conjugation of glucuronic acid with the drugs. And what type of drugs are there? This occurs in liver. Number one, aliphatic alcohols, phenols are commonly conjugated with glucuronides. Phenol example is phenytoin. Then for example, the metabolites of morphine. Metabolites of morphine can be glucuronide, can be conjugated with glucuronidation. Then we have acylation, especially acylation with acetyl groups, for example sulfonamides. Sulfonamides are antibiotics used against the bacteria. Then we have glycine, for example nicotinic acid, sulfate, sulfation, for example morphine and paracetamol. then we have another important phenomenon. Those were the phase 1 and phase 2 reactions and the type. So we have another phenomenon, enzyme induction and enzyme inhibition. We talk about in terms of cytochrome P450. Cytochrome P450 enzymes. If any drug, induction means if any drug increases the quantity of cytochrome P450 enzymes or any specific cytochrome P450 enzyme. For example, if you know that drugs are molecules, drugs are chemical entities. So if any drug can increase the quantity of cytochrome P450 enzyme, this is called enzyme induction, and the drug which has increased the quantity of the enzyme is called enzyme inducer. So for example, phenobarbital is a drug. This will induce metabolism of itself, phenytoin and warfarin. So what happens is, look, phenobarbital is a drug, is a chemical moiety which will increase the enzyme level. And any other drug, that was the drug A, and the drug B, which is metabolized by with that enzyme. So this will induce the metabolism of that drug. And what is that? The drug A is phenobarbital and drug B is phenytoin. If we give these two drugs at the same time, the phenobarbital will increase the metabolism of phenytoin, thereby it will decrease the quantity of the phenytoin. So thereby other chemicals, for example cigarette smoking, can cause increased elimination of theophylline. So thereby drug may be eliminated early as anticipated because of increased metabolism, and we need to give or we need to administer drug on a frequent. On the other hand, what is enzyme inhibition in terms of cytochrome P450 specifically? Any chemical, any chemical moiety, any drug, any substance that decreases the quantity of the enzyme, that is called enzyme inhibitor, and the process is called enzyme inhibition. For example, grapefruit juice. If you give some drugs, for example warfarin, or any drug, that warfarin is being metabolized by 2C9, but if you give warfarin with tolbutamide, so warfarin being the enzyme inhibitor, it will inhibit the elimination of tolbutamide because it will decrease the enzymes that metabolize tolbutamide. This is drug A, this is drug B, and in this you have to give drugs together. And cimetidine, another potent drug that can inhibit the enzymes. And what are the factors that can affect drug metabolism? For example, age. Drug metabolism is slower in fetal, neonatal and elderly humans than in adults. Elderly and the children, they have slow metabolic processes, so we need to reduce doses. Women, for example, gender, if we talk about women metabolize alcohol more slowly than men, and similarly the capacity of females to metabolize certain drugs is less than male. So we need to give lesser doses in addition to their body surface area. Enzyme induction and enzyme inhibition, the presence of other drugs. For I just told you drug A and drug B. If drug A increases the enzyme that metabolizes drug B, then we need to give a greater quantity of drug B. Food, for example, grapefruit juice or the barbecued meat, they have an effect on metabolism, genetic variations, enzymes can have different forms. For example, N-acetyl transferases, these are involved in phase 2 reactions. Individual variation creates a group of people who acetylate drugs. For example, isoniazid, it's an anti-tuberculosis or anti-TB drug, slowly. These are called slow acetylators. And those who acetylate quickly are called fast acetylators. So now the drug will be metabolized slowly. So we have two scenarios. Number one, we have individuals, the drug is same, isoniazid. So first thing is drug, that is isoniazid. And now there are two types of people. Number one, slow acetylators, and number two, fast acetylators. Fast acetylators will metabolize the drug quickly, the drug isoniazid. And other type of people who are called slow acetylators will metabolize the drug very slowly. Say you have given any milligram of isoniazid, for example 100 mg of isoniazid to these people and these people. We have made two sets. Number one set, the set number one has the people which are called slow acetylators, or set 2 has the individuals which are called fast acetylators. So now think what will happen to them. If you give same dose 100 mg isoniazid to slow acetylators, they will slowly metabolize. This is a phase 2 reaction. They will slowly metabolize the drug. So it means the drug will be excreted out of the body very slowly. And while other people or other individuals that belong to set 2, which are fast acetylators, they will quickly or they will very fastly metabolize the drug and excreting the drug out of the body. So thereby they need greater doses as compared to slow acetylators. So this, for example, the variation may have dramatic consequences. What are those dramatic consequences? As the slow acetylators are more prone to dose dependent toxicity. What is that? If you give larger dose to these slow acetylators, these doses can accumulate within their body. The drug may accumulate within the body, and ultimately these can undergo or can experience adverse drug reactions. For example, if we see 13% of Egyptians are slow acetylators, they can have a bleeding from warfarin. Then there are physiological factors that can influence drug metabolism, like age, individual variation, pharmacogenetics, enterohepatic circulation, intestinal flora, or sex differences. Then we have pathological factors like liver disease. The major organ that metabolizes the drug is liver. If liver is not functioning properly, this can also affect the drug metabolism. So we need to adjust the dose. Kidney. After the metabolism, drug must be excreted out, or the metabolite must be excreted out of the body. If kidneys are not functioning properly, kidney failure is there, then kidney may not be able to excrete out. So what will happen? The metabolites or the drug can accumulate within the body. Then we have another phenomenon called drug excretion. We have different major organs, as we have discussed in class, that drugs can be excreted out by many routes. For example, drugs can be excreted out through kidneys by the urine. Then we have fecal excretion through the feces. Then we have pulmonary through the breath, salivary through the saliva, into the saliva. Then we have mammary glands or the milk. Drugs are excreted in milk. These are important when we take, or when we consider the safety of the drug for the fetus, nursing mother. So what are these? So what and how we will describe drug excretion? How would we define drug excretion? This is the reversible loss of drug from the body, primarily via kidney and bile, feces, sweat, saliva, tears, expired air, and breast milk to lesser degrees. We have already described. So main is kidney and bile. So excretion is not equal to elimination. Just remember this. What is excretion? It is an irreversible loss of drug from the body. And what is elimination? It is an irreversible loss of parent drug by metabolism and or excretion. So in elimination, both metabolism and excretion are occurring, while in excretion only the excretion or the removal from the body is occurring. This is how I can explain what is elimination. As long as the drug is being metabolized, the drug is being changed, so body will get rid of it. So both the processes, the change of the drug by metabolism and excretion, will be called as elimination. So kidney, again going back to physiology, there are three processes that occur that bring about the excretion through urine. These are passive glomerular filtration, active tubular secretion, and passive tubular reabsorption. Here you can see is the diagram of a nephron here. So one thing. So this is, let me show you. Just bear with me. I'm going to show you how this will happen. Here the example of phase 1 and phase 2. We'll come back to it. this is the elimination. This is total amount of drug taken. This is lipid soluble, water soluble. Here the lipid soluble comes to the liver, water soluble goes to the kidneys, and then it comes to the liver. After liver, it might bind to the bile if it remains a lipid soluble. But if it becomes water soluble after metabolism, the phase 1 and phase 2, then it goes to kidneys, or the drug may go into skin by perspiration or the sweat, and it can and the drug can go to the lungs as well. The beautiful diagram was there. I was just looking for that. Here you can see. So you can have a greater idea with this how the kidney functions. This is a renal artery. Here the blood comes to the Bowman's capsule. Here is a glomerular filtration. This is the lumen of the nephron. Here is the loop of Henle, proximal, and then there is a distal convoluted tubule, and then there is one thing. This is the blood supply. The peritubular capillary comes around this. Now you can see the blood here. It is coming towards the kidney, while this is away from kidney. The deoxygenated blood away from kidney, and this is oxygenated blood coming towards the kidney. So anything. Now what happens? All the materials get filtered into the urine, but not all the filtered load is being excreted out. Certain things get reabsorbed, while certain things come back. For example, here you see anything. What is glomerular filtration? There are three processes: glomerular filtration, tubular reabsorption, and tubular secretion. Here, what is glomerular filtration? This you can see. Here the membrane, the glomerular filtration occur from the glomerulus or glomerular capillaries. This is called glomerular filtration. Anything that comes from blood into kidney, or into the nephron, this is called tubular secretion. Here you can see coming arrow from the blood into the kidney. So this is called tubular secretion. While anything that goes from the urine lumen or from the nephron to the blood vessel, this is called tubular reabsorption. So why it is called reabsorption? Because first time it was absorbed. For example, if this is sodium, so this sodium was first absorbed in the small intestine, and second time it is being absorbed coming back into the blood. Absorption, is anything that is added up in the blood. So second time it is being reabsorbed, or it is being absorbed in this blood vessel, so that is why it is called reabsorption, tubular from this tubule. So glomerular filtration, tubular secretion, and tubular reabsorption. There are three processes, and these processes govern the process of drug excretion. So what is glomerular filtration? This is peritubular capillary. Here you can see drug in the blood, and here the drug comes in the urine. What happens? It is glomerular filtration is a passive process. Passive means it doesn't require any energy. So free drug means which is not plasma protein bound. There are two conditions for the glomerular filtration. Number one, drug should be free. It should not be bound to plasma protein, and second, its size should be 20 kilodalton. It should be less than 20 kilodalton, right? Then there is active tubular secretion, separate transport system for weak acid and weak bases. These are active. So the difference here from glomerular filtration, that was passive process, while tubular secretion, what is tubular secretion? Anything that comes from the urine lumen into the blood supply. This is called active. This is active process with the help of energy. And there are two different systems, two different transporters are present for the transport of drug from the tubule into the blood. From the blood into the tubule. Organic anion transporter and organic cation transporter. Then we have passive tubular reabsorption. Tubular reabsorption is anything that comes from the tubule into the blood. That is also a passive process. And if you remember the iron if you remember the process of pH, partition theory, the pH is the key. Ion trapping. I just skipped. So ion trapping is a phenomenon which governs this tubular reabsorption. So here we can see many drugs are either weak bases or weak acids. So therefore the pH of the filtrate can greatly influence. What is that filtrate? Filtrate that is present in the urine lumen or the when urine is acidic, weak acidic drugs tend to be reabsorbed. Alternatively, when urine is more alkaline, weak bases are more extensively reabsorbed. So what happens? What actually this phenomenon is here. This is the peritubular capillary and this is the urine. Here are the arterioles. Anything that is filtered from the glomerulus will come in this nephron, and anything that is coming from the nephron into the blood is called reabsorption, and for reabsorption it is absorption. We have discussed in a much detailed manner that which principle governs the absorption: ionized form and unionized form, if you remember. So we discussed acids or acidic drugs tend to absorb in a best way in acidic medium because they do not get ionized, they remain unionized, while basic drugs best absorb in basic medium because they remain unionized. If opposing the pH of the medium, for example, acidic drug in basic medium, what will happen? The drug will become ionized and its absorption will be hindered. So what happens? What is ion trapping? It is here in this urine lumen, the drug, if the drug is unionized, Here the active tubular secretion and the passive tubular reabsorption. So we are concerned with this arrow and with this process. Number 3, in this process, if the drug is unionized in this form, in this place, the drug unionized, it will aid, it will help out the absorption. So drug will move from the urine lumen into the peritubular capillary. So this will be called as tubular reabsorption. But what happens when the drug is in ionized form in this chamber? Then the drug will not reabsorb into the peritubular capillary and into the blood. It won't go into the blood. So this is described here. For example, when urine is acidic, weak acidic drugs tend to be reabsorbed. Alternatively, when urine is more alkaline, weak basic drugs are more extensively reabsorbed. So now, what happens? What factors can change the pH? The pH of urine remains or varies from 4.5 to 8.0, from slightly acidic to slightly basic. What factors can vary this pH between these two values from acidic to basic? It can the consumption of meat, meat has proteins are made up of amino acids are made up of amines, and deamination occurs in liver, and then this can cause acidification of urine. And drugs which can increase or decrease urinary pH, for example sodium bicarbonate, if given, this is a basic substance, and this can cause basic pH. So now the scenario in cases of drug overdose. For example, here again coming back to this slide, someone ingested aspirin in a larger quantity, drug overdose. This can cause serious reactions. So what we do, once the drug aspirin is acetyl salicylic acid, so the name shows that the drug is acidic or weak acid. So once the drug is filtered from this side, from the glomerular into the urine lumen, it is likely, if it remains unionized, if the urine is acidic, drug is acidic, it can reabsorb from this site to the blood. While if drug is unionized, this acidic drug is unionized in this medium, this cannot be absorbed, or this cannot be reabsorbed into the peritubular capillary. So what we do, if a known case of poisoning or drug overdose is there, and we know which drug he or she has taken, we can cause, or we can oppose the medium, or we can cause the medium or the pH of the urine lumen, we can cause it to change. For example, acidic drug is being taken, so we can give a glass of alkali or the base which the patient can drink. So ultimately this can cause urinary alkalinization, and once the urinary alkalinization means the pH of the urine is on the basic side. So the drug is acidic, the urine is basic, so ultimately this will cause the drug to be ionized in this, and ultimately it will hinder the passive tubular reabsorption. So what is renal clearance? clearance is if we mathematically define excretion. This is called clearance. How would we define clearance? How much time or the unit time taken by the drug to clear the plasma. We know the amount of plasma in our body, and we know the amount of drug or the quantity of the drug or the plasma concentration of the drug. So if we equate now, so renal clearance is equal to rate of excretion over plasma concentration. For example, rate of excretion is high, so it will take less time for the plasma concentration to fall. If the rate of excretion is low, then it will take plasma concentration to fall considerably with a delayed time. So factors altering drug excretion, renal excretion, elderly and newborn, again these processes are slowed down in very young children and elderly. Women have 20% less than men. Kidney and heart diseases, kidney diseases. In the kidney diseases, what will happen? The capacity to excrete out drugs will be much less. While in heart diseases, the cardiac output or the pumping ability of the heart is disturbed. For example, congestive heart failure. So patient taking drugs which block secretion. Then there is fecal excretion. Fecal excretion is occurs by two processes. Either of two processes, you can see. Excretion in bile, for example, morphine and chloramphenicol are excreted, or some heavy metals like arsenic, lead and mercury. They bind with the bile, and the biliary secretion is active since bile plasma concentration may be as high as 50:1. There can also be a competition between compounds. For example, two drugs can compete for the binding with the bile. Then this is how it happens. For example, drug in blood, renal excretion, this is out. But metabolism, conjugate in liver, conjugate in bile, conjugate in intestine, because bile is excreted in intestine. Secreted in intestine. So in intestine, the enzymatic breakdown of the conjugate. Conjugate means the phase 2 conjugate. Drug again will be liberated in. So this is called enterohepatic circulation. Or conjugate in intestine. If this doesn't occur, this can go into feces. So this is how the biliary excretion occurs. Drug in blood, phase 2 metabolic reactions. Then the drug binds with the bile. In the bile, it comes to intestine, and through the intestine it goes into the feces. This is the first mechanism by which drug can be excreted into the feces. The second is direct intestinal excretion. So that is again from the small intestine. If the drug is not absorbed, then it can be excreted out. Drug may be excreted by passive diffusion from the pulmonary excretion. Most of the gaseous anesthetics are extensively eliminated in expired air. Then we have salivary excretion. For example, certain antibiotics may cause black hairy tongue into the saliva. Gingival hyperplasia are the side effects of phenytoin. Here you can see This is the black hairy tongue, while this is gingival hyperplasia. You can see the gums have swollen. Then we have again, the breast milk is a bit of slightly acidic. The pH is around 6.5. So it is acidic than the blood. So certain basic substances or lipid soluble compounds can come in the milk, because the breast milk has fats as well, so it can dissolve lipid soluble compounds, and it is slightly acidic. It is quite acidic as compared to blood plasma, so basic substances can be trapped in the breast milk. So since the milk contains 3 to 4% lipids, lipid soluble drugs can diffuse along with the fats from plasma into mammary gland. Or what other drugs can, for example, substances that are chemically similar to calcium can be excreted into milk. Ethanol and tetracycline enter the milk by diffusion through membrane pores of mammary alveolar cells. So tetracycline can come in breast milk. So these are the processes, or these are the drugs which can come in mammary or the breast milk. So these can harm the fetus. So nursing mothers or who are feeding their children must take care of the drugs which they are taking. Thank you very much. See you in next lecture.